Hello and welcome to Front and Centered, hosted by me, Patrice Charlotte, Communication Specialist for Equity and Community Health. We are so excited to have you all join us today as we invite you to witness the extraordinary work of two visionary pioneers who are revolutionizing the landscape of medical care. In a world where medical care can often feel impersonal, Dr. Sharl Azar leads the charge in creating a comprehensive sickle cell disease treatment center like no other. This innovative center, born out of a passion for holistic healing and with partial funding from Equity and Community Health, fosters a haven of trust, understanding, and unwavering support, a true medical home where patients are cherished. Meanwhile, Dr. Abraham Cohen is on a mission to dismantle the barriers that prevent equal access to life-saving kidney transplants. Recognizing the alarming disparities faced by communities of color, Dr. Cohen and his team bring hope directly to the heart of the community, providing a lifeline where it is needed the most. Today, we are honored to have these extraordinary visionaries join us. Together, they're here to share with all of us more about their remarkable initiatives and how they are revolutionizing clinical care while eradicating systemic inequities. Uniting the power of compassion, knowledge, and innovation, both Sharl, Abraham, and their teams aim to create a future where no one is left behind. So before I turn things over to our presenters, as a reminder, we do encourage comments and questions, and we will have a dedicated Q&A at the end of the presentation, should time permit. We ask that you save questions until the end and submit them by using the Q&A button located at the bottom of your window. Should you have any comments, please feel free to put those in the chat. And so with that, I will now turn things over to Dr. Azar to get us started. Sharl?
Well, thank you so much, Patrice. I really appreciate that very generous introduction. Let me share my screen and get my presentation up here for you guys. So, there we go. Well, it's such an honor to be with you guys today. I just want to take a few minutes today to talk to you about the work that we're doing in our Comprehensive Sickle Cell Disease Treatment Center, which is a relatively new endeavor here at Mass General. I've been here now for about 3 years, and that's about the length of time that our program has existed. Prior to me being here, there was not an adult sickle cell program in place, and our goal in trying to build our sickle cell program is to build a true medical home for patients living with sickle cell disease. Over the course of just the next couple of minutes, I want to briefly talk to you guys about what sickle cell disease is, because if you have not been able to take care of patients with the disease, unfortunately, very few people really know how the disease works. I want to talk to you a little bit about the dangerous crossroads that our patients often find themselves at by no fault of their own, and then talk a little bit about the ways in which our program is working to combat those challenges that our patients face. So very quickly, just a quick background on sickle cell disease itself. Sickle cell is an inherited life-threatening blood disorder, and it impacts about 100,000 people in this country alone. That number has not changed in over 3 decades, and that's largely because that number is made up. We're so far behind in our understanding of sickle cell disease that unfortunately, we don't even know how many people actually live with the disease in this country. The reason for this enormous disparity in our understanding of the disease is simple. It's because it is one of the few diseases that largely impacts Black and brown people. 1 in every 13 Black babies in this country will be born with at least sickle cell trait. The disease really goes on to touch every organ in the body. A quarter of our patients will have had a stroke before they're 40. Many of our patients will need joint replacement surgery by the time they're in their 30s. Some will have had their first MI in their 20s. The disease goes on to affect the kidneys and the eyes. It can lead to life-threatening multi-organ failure, severe priapism, skin ulcers that take several months to years to heal, all of which ultimately leads to a curtailed life expectancy, as the majority of our patients will sadly not live to see their 45th birthday. The majority of our patients live at this awful crossroads. The nation's opioid epidemic and our long overdue national reckoning with race. On the screen, you see a comparator between sickle cell disease and cystic fibrosis. Cystic fibrosis is an absolutely terrible genetic disease, but we use it for comparison's sake here because CF primarily impacts Caucasian population, whereas sickle cell disease, as I mentioned, largely impacts Black and brown people. And you can see that the incidence of sickle cell disease is higher than that of cystic fibrosis. But despite that, sickle cell disease is outspent when it comes to NIH funding by over 2 to 1, by private insurance, private industry funding by 3 to 1, and by philanthropy by 80 to 1. When you compare sickle cell disease to other chronic congenital cousins like hemophilia, there are drastic differences. Hemophilia is a federally funded disease. There are national regulations surrounding what defines a national hemophilia treatment center, and that funding then comes from the federal government that allows centers to be able to pay for their resources. We have known about the genetic cause of sickle cell disease far longer than we have known about the genetic cause of several of its chronic congenital cousins. And despite that, we are so far behind in our understanding. Hydroxyurea, the mainstay of our treatment, was approved in 1999. And up until 2018, we had absolutely no other therapies. To date, this antiquated medication remains the only medication that has actually been shown to improve mortality in sickle cell disease. The behavior of all of us as providers in caring for our patients truly matters. We hear things as we care for our patients wandering around the hospital all the time that are rooted in a lot of the inequities and limited understanding related to our disease. We hear things like the patient can't possibly be in pain because they're asleep or they're on their phone all day, or the patient has to be a drug seeker because they're coming into the emergency room and they're asking for a very specific pain regimen. All of these things lead to our patients being afraid to tell us when they're being mistreated or misspoken to in the hospital, because they're afraid that if they do so, it will limit or change the way that we care for them. Ultimately, the data has demonstrated for us that the rates of opiate misuse in sickle cell disease are lower than other chronic congenital diseases and lower than the general population overall. But despite that statistics, our patients are still treated like they are drug seekers. One of my favorite studies is the study that was done not long ago with 413 medical students, residents in internal medicine or in the ED, that were presented with one of 2 medical records that differed only in the way that they describe pain. And those learners were then asked to choose between one of 4 options for pain control. Those trainees that read the notes that used the biased language were far more likely to select a less aggressive pain regimen for the patient and have an overall more negative attitude towards the patient. And sadly, the further along they are in their training, the more negative their attitude was. This is further backed up by a series of surveys that have been done over the years. In 1997, one survey showed that 50% of ED physicians and a quarter of hematologists, my own colleagues, believed that sickle cell patients were addicted to opiates. In a 2005 survey, 86% of teaching hospitalists didn't believe that the patient's own report of their pain was the actual best indicator of their pain level. The things we say, the way we treat our patients desperately matters and deeply impacts the kind of care that they receive. So how are we working to undo this here at Mass General? Well, I'm very proud of the multidisciplinary team that we have put together. And on the screen now, you are seeing some of the extraordinary people that come together to provide care for our patients. I always say that I'm the least important member of this team, that we, as a physician, there's only so much that I can do for these patients. The disease goes on to impact them so much outside the 4 walls of this hospital, and it really does take a multidisciplinary team to be able to provide them with the best care. We are so lucky to have 2 dedicated nurse navigators in our center, Ellen Silvius and Sharon Amos, a dedicated social worker, Kate Quint, and a patient navigator, Rose Francois, who really helps to untangle the medical system. We have a group of 8 primary care doctors that are embedded in our clinic to allow patients living with sickle cell disease to, for the first time, have dedicated primary care in addition to subspecialty care. And because this disease touches nearly every organ in the body, as we just went through, we need a specialist for every organ in the body. So we're so lucky to have the group of specialists that you see there in the middle. And then I'm particularly proud of our pain and suffering management team. Because sickle cell disease is so deeply defined by the severe and excruciating pain that the disease can induce, it's imperative for us to be able to think outside the box in how we take care of our patients. So we're fortunate to be able to have integrative therapies, mindfulness, palliative care, and spiritual care, who all play such integral roles in the way that we take care of our patients. Beyond this, because the disease touches our patients and their families and their homes and their lives outside of the hospital, it's important for us to be able to provide them with social supports. We're lucky to be able to partner with an organization called Year Up that can provide our patients with college courses and potential paid internships with benefits. We have a partnership with Caritas Communities to work on the housing deficiencies that our patients experience. Uber Health allows us to be able to provide patients with transportation thanks to a really generous grant from the Bird Trust. We've partnered with AT&T to give our patients who don't have access to mobile access to cell phones, and we are able to pay for their plans so that they can communicate with us. And lastly, we have gifts from the Slavin Fund and the Vertex Foundation that have given us some resources to be able to help patients pay some of their bills or cover their rent or any of the other expenses that would otherwise keep them from being able to dedicate their attention to being well and healthy. I'm really proud of the fact that we're innovating in this space. We have created a new athletic training program. There is no data to demonstrate the role of wellness and nutrition in patients living with sickle cell disease. In fact, the opposite. Our patients with sickle cell disease have been told their entire lives that they can't participate in organized sports and cannot exercise for fear that it will set off their disease. This, of course, leads to additional health problems down the road. So we're so lucky to have a dedicated athletic trainer who brings a special expertise in chronic disease to help our patients be able to train appropriately and safely without exacerbating their disease. We are creating the first in the country survivorship program to allow those patients who are undergoing the new potential curative treatments like gene therapy to actually continue to receive ongoing care after they've received this intervention as we learn what the long-term consequences or benefits of the treatment are going to be. And because so many of our patients succumb to their disease early, it's imperative for us to be able to provide resources for the families that they leave behind, which is where this survivorship program really comes into play. And then lastly, we are building a patient support group and an advocacy group so that our patients' voices are front and center in the way that we care for them. I'm so proud of what this team has accomplished, and I'm so excited about the places that we're going to continue to go as we build a true medical home for patients living with sickle cell disease. And with that, let me hand it over to Dr. Cohen.
Thank you very much. First of all, it's an honor to be here. Thank you very much to Patrice for the nice introduction. Let me just share my screen. Does that look okay? Perfect. So I'm going to be talking about this equity in kidney transplantation initiative that we started about a year ago, which aims to improve access to transplantation for underserved communities. So a little bit of background first. So the incidence of end-stage renal disease is 2 times higher in Hispanics and 4 times higher in African-American patients compared to non-Hispanic whites. These patients, the minority patients, get worse CKD care. So they have worse anemia, worse timing to the place of dialysis access, worse blood pressure control, and many other measures. We know that kidney transplant is the best option for advanced kidney disease. That's the best treatment that we have. However, patients from minority groups, they have less access, less likely to be referred for transplantation, less likely to be listed for transplantation before starting dialysis. Their wait time to get a transplant is longer. They're less likely to receive a kidney transplant and less likely to receive a living kidney donor. So with all that in mind, we looked at our own center, what we were doing, and we saw that around 26% of our patients, of our list, is comprised of Black and Hispanic patients. But based on the population makeup of the area that we serve and the incidence of CKD in those populations, we would expect that that number would be closer to 50%. So we're doing much worse than we should be doing. So based on that, we created this initiative. But before I move on to tell you a little bit more about the initiative, I wanted to talk to you a little bit about the causes of all these issues, all these disparities. And there are multiple causes. For example, there is genetic factors, like, for example, the APOL1 gene variant that predispose African Americans to develop chronic kidney disease. There is also social determinants of health, low socioeconomic level, and many other barriers that don't let patients get proper care. And there's also systemic racism and systemic problems, barriers that these patients encounter. One big example is how we used to measure the GFR, or the kidney function, for especially for African American patients. That would initially would prevent patients from getting the proper care, because it would tell us that the kidney function was higher than it is actually. So based on that, we created this initiative. We call it Equity in Kidney Transplantation, EqKT, and we base it with three pillars. So the first pillar is care in the community. So instead of bringing the patients into MGH, we go into the community. We are going once a month to the Chelsea Health Center, and we evaluate patients for transplantation over there. We take a multidisciplinary team, which involves me as a nephrologist, Lara Cornacini, which is the social worker, Isabella Vaquero, who is the health and wellness navigator, and also Jacqueline Almestica, who is the social worker. So a multidisciplinary team, we go there and we see the patients, we evaluate them for transplant. The second pillar, it involves care and resource navigation. And as I said, we have a navigator, Isabella, who does a great job on helping the patients navigate a very complex system to get them to the list and then complete their workup to get a transplant. And the last pillar is quality improvement. We're tracking all of our measurements and all the data to try to improve how we deliver care. This is a busy slide, but I'm not going to take too much time on this slide. I'm going to just explain what it means. So this is just the roadmap of how patients, what needs to happen for patients to get a kidney transplant. So, of course, first they have to get the CKD diagnosis, and patients of minorities, they get diagnosed at later stages. Then the patient needs to be aware of the diagnosis, and they're less aware of their diagnosis. Then they have to be referred to a nephrologist. The nephrologist usually refers them to a transplant center, and as we already discussed, they get referred less often and at later stages to transplantation. So on all those stages, what we've done in this Equity in Kidney Transplantation initiative is we've done virtual group visits that encourages patients to take care of their own health, take better care and get healthy lifestyles to get better measurements in terms of diabetes, hypertension, and their kidney disease. We also created educational materials. In MGH and in whole MGB system, we are now using the race-free equation to calculate the GFR, or the kidney function, which is very important. After they get referred to the transplant center, so then we evaluate the patients, and now we're evaluating them in Chelsea, those patients, which is a community. Chelsea is a community that mostly Hispanic patients live there, but also several African Americans. And the multidisciplinary thing that we go there, we're all bilingual. So we try to get rid of some of the barriers for them to come to see us. Also, we are using Uber Health to get patients to their appointments to help them with transplantation. Then after they get evaluated, they have to complete several steps, a lot of workup, a lot of studies. And we have the health and wellness navigator, Isabella, that helps them, as I said, navigate the system and get everything done. Then we get together, the whole team, the whole transplant team, and we discuss those patients, and we have to get listed for transplant. And during that step, we partnered with an independent researcher from Tufts and UNOS that document all these implicit bias that we might have, and if we do have implicit biases during the transplant listing meeting, to reduce those biases. After they get listed, the patients need to wait for a long time to get a deceased donor transplant, or they have to identify a living donor, and then that living donor needs to go through a lot of workup again to get approved and then get a transplant. And in those steps, we created these webinars of how to that we teach the patients on how to find a living donor. So what have we done in the last year? So we started this initiative in March 2022, and I'm presenting the data up to March 2023. We've scheduled 67 patients to be seen in the Chelsea clinic. 22 of those either no-showed or canceled their appointments. This was much higher initially. It was up to like 50%. Since we have the navigator, it has come down because the navigator helps with the transportation and also reminds the patients that they have this visit. 52 patients were evaluated. Out of those, 3 patients are still in the evaluation process and they still have to do some more workup. Out of those, 26 patients have been waitlisted, and we already transplanted 1 patient that went through the whole process. There is a second patient that we already transplanted, but was listed even before we initiated this program, but also got the benefits of having the transportation and many other things that the navigator helped him with. The patients that come and see us in Chelsea come from Chelsea, Lynn, Revere, and that area, but also they come all the way from Lawrence, from Boston, and they also come sometimes from the south, in New Bedford, Cape Cod, or even Nantucket. So with that, I'll pass it to Patrice, and thank you very much.
Thank you. Thank you both for such an eye-opening and striking presentation. That was so informative. And so now I would like to open up the Q&A portion of the webinar. And these questions are for both of you. I have a lot on my mind, Sharl, a lot on my mind, Abraham, and I know that our audience does too. So for folks, as a reminder, if you'd like to submit a question, just hit the Q&A button located at the bottom of your window. So up first, for both of you, why do you do this work? What brought you here? What inspired you? What's your why?
Abraham, would you like to go first?
Sure, I can go first. So I'm actually originally from Mexico. So coming to here and moving to the US, I really wanted to give back to Hispanic population, and I knew that there was a lot of disparities, and I also know about all the disparities with African Americans. So I really wanted to give back to these populations to help them get better access to transplantation, which is the best treatment that we have, and they do much better. Patients, we see so many patients that have been for many, many years on dialysis, just doing very poorly, and having them transplanted and seeing how their life changes is just so rewarding. That's the main purpose.
You know, and likewise, from a personal perspective, you know, I'm the son of immigrants. My parents are both from the Middle East. The Middle East is one of the second highest endemic areas impacted by sickle cell disease in the world. But beyond that, you know, when I was a medical student, I encountered my first sickle cell patient in the ER, and I watched the ER provider at that institution tell that patient that he needs to go get his fix somewhere else. And I watched that patient sort of pull himself together, because he had certainly not heard that. You know, it was not the first time he was hearing it, and he managed to walk out with dignity intact somehow. And I just thought to myself, we need to do better. We need to allow our patients to be able to feel that dignity when they're getting their care.
It's amazing. Your patients are both so lucky to have you. We did get a question from the audience, and so for both of you, do either of your services employ community health workers or CHWs? And if yes, what are their roles and what have you noticed in terms of the value they add to the team?
Do you want to go first, Charles?
Sure. So I can say that we are actually in the process of trying to plug into the community health worker pool. Now, we've long wanted to be able to have a community health worker. Once we got our social worker, Kate Quint, on board, now we really want to be able to have a community health worker to sort of be an extension of the work that she's doing A lot of our patients need assistance, sometimes even just making it to appointments. And our patient navigator is great at being able to help make those organize those appointments for them. But sometimes it really is helpful to have someone actually physically go with the patient. So we anticipate our community health worker will play that role. They will help with a lot of the paperwork that we often need to get them housing, to get them vocational training, et cetera, et cetera. So we're really excited to be able to have that role filled.
Yeah, in our program, we haven't officially worked with community health workers, but our social worker gets in touch with them very, very often and tries to get their help. So we don't have an official partnership, but we do get in contact with them whenever it's needed.
Awesome. So we have another question for you both. What do you think is the impact of disclosing this condition as a result of coming from a different culture or background? So, are there any implications? Is there any impact that culture has in this work, in disclosing the diagnosis?
Go ahead, Abraham.
Sure. Yeah, there is so much in there. I mean, especially in Hispanics and African Americans, it's very difficult to talk about transplantation, especially living donation. That's why the rates of living donation is so low in these populations. They have so many myths and misconceptions about living donation. So it's very important to try to disentangle these myths and like myths, for example, that after donation, they'll do really bad. They have to take medications, sexual problems, and like all of those are just myths and are completely false. And we're trying to get, like with those webinars that we're doing and the virtual group visits, we're trying to teach these patients that those myths don't exist and they should move forward with donation.
And likewise, I can say that, there's an enormous trust barrier to be overcome in the care of our patients. There's an enormous trust barrier about the healthcare system on the whole that we've had to work to overcome, and that we continue to work to overcome. We recognize that the trust we build with our patients is earned. And so the hope in building a true medical home where these patients can feel seen and heard is an effort to try to help overcome that trust barrier. Outside of this country, where the vast majority of patients with sickle cell disease live, there are a lot of taboos surrounding the disease. Some of the language that's used to describe the disease centers around the horrible pain that it causes. And because these patients suffer so much, they're often ostracized in their own communities. So many patients are afraid to come forward and even talk about the disease, even though it's so endemic.
Thank you. This next question is actually for you, Dr. Cohen. And so one of our audience members is hoping that you can expand upon examples of implicit biases that are being picked up on in your space.
That process, we just started that program with an independent researcher. They've met with us several times and they join our meetings, selection meeting, I think only twice. After certain sessions, I think 6 or 8 sessions, they'll come back to us and tell us what they found. But there are multiple implicit biases that I would think that could come up, like just talking different about a specific patient because they are from some race or some different background, and we need to do better. So that's why we're partnering with them.
Fantastic. Our next participant had asked and said, thank you for this incredible work and commitment to these vulnerable populations. What are the greatest challenges each of you face within your respective centers, and how are you addressing or hoping to address them?
Well, that's an excellent question. And I think the biggest barrier that we face is the systemic racism within our healthcare system, plain and simple. We have to combat that every single day. The way that our patients are treated, the way that our patients are spoken to, the way that the disease is reflected upon. I operate in a data-free zone as a sickle cell provider because medical science has not cared about this disease and has not provided me with treatment options, nor has it provided me with data to actually be able to manage these patients safely. Most of what I do is based on expert opinion, and it's largely because my patients are Black and brown.
Yeah, same in the kidney realm. There's a lot of, again, misconceptions and that it's difficult to see the patients, and if they don't know what's happening with their body and what's going on with their health. And that, I think, more education is probably the most important barrier that we've encountered.
All right. And so for our last question, would love to hear from you both. What would you like your colleagues to know?
Go ahead, Sharl.
I think what I would like my colleagues to know is that this disease and the pain that my patients experience is very real, and that my patients should be believed when they come into the emergency room or when they're admitted to the hospital, and that the disease should be taken very seriously. It also requires a multidisciplinary team, and we are readily available to help all of you as you care for our patients. Don't ever hesitate to reach out to our team.
What I would say, my colleagues, is that so kidney disease is very, very common, especially more common in minority patients, and that we can treat them better. We can get them into transplant, and we can give the care that they actually need.
Well, thank you. Thank you both. Everybody, that concludes this month's Front and Center. Thank you again to our presenters and for all of you for attending. We do hope to see you on June 29th at noon for our next webinar, where Equity and Community Health Strategy and Implementation Officer Leslie Aldrich will be sharing updates on the MGH Community Health Impact Funds, a historic investment in the communities we serve. So again, thank you all for coming. Thank you, Sharl. Thank you, Abraham, and to everybody on the call. Take care, and until next time, bye-bye.